Hello, everyone. Thank you very much, Robert and Maureen, for inviting me to Toronto. It's not my first visit to Toronto, but it's going to be the first time I lecture to patients, or rather talk with patients, as well as our medical colleagues. So I make no apologies. I will use technical terms, but this is how I treat my patients. They have to understand their disease, and that helps us to manage the treatment. Now, I'm going to ask you to help me. I've left out some important people in this list. This slide was made when we first set up our multidisciplinary team. And can anybody tell me whether I've missed somebody out? Well, patients, sadly, we still don't have patients in the multidisciplinary team meetings. And maybe what we would aim for is that when your case is being discussed, you should then come in. But clearly, it would be very difficult for us to discuss other patients in your presence. So maybe patients, definitely, I think so. I feel I give them the multidisciplinary team view anyway when I see them. Anybody else? Pathology, exactly. Our histopathologist is now absolutely essential. For instance, if we want the key 67 data, and I have to say, I say Kai, the key 67 data, we need our histopathologist there. So that's crucial. There's somebody else even more important. No, I take the patient to the cardiologist if we need to. So the nurse, our nurse specialist. And at the time we started, which was several years ago, we didn't have a nurse specialist. And now, really, without her, we couldn't function. Thank you. Now, you've seen this slide before, actually. But it's not very well projected, and we've still got all the lights problem. Well, anyway. Basically, I really wanted to highlight that if you have a neuroendocrine tumor, your primary can arise from anywhere in the body. On the right side, and I can give you copies of this slide because I think it's important. On the right side, you can see lots of neuroendocrine tumors from the adrenal gland region, from the neural crest. On the left, and I'm afraid I can't do them myself. On the left, the GI endocrine cells, which are the ones I think most of you will be familiar with. But I make no apologies for including things like the women's gynecological aspects, because I have a little story to tell you. That this poor young lady, her mother had died of a neuroendocrine tumor of the cervix. But her father insisted that she must have been rather promiscuous and had papillomavirus. And indeed, the same young person is now in medical school, and the lecturer in infectious diseases told her there was only one cause of cervical cancer, papillomavirus. And clearly, this is very upsetting. You can get a neuroendocrine tumor of the cervix, and it's got nothing to do with your sexual habits. We're all in a position where we can get anything. Mostly it's due to our genes, but sometimes even that is not the cause. We don't know yet. We had a very interesting talk about the future, that we will be targeting genes for therapy. And if you like, that's my take-home message, is that it doesn't end here with just peptide therapy. We will be going on to gene therapy, and this is really just round the corner. Most of you will be very familiar with the symptoms of the carcinoid syndrome, and you'll also be familiar with the sort of hormones that produce these syndromes. Talking about flushing is such a bad term, isn't it? And somebody already has alluded to this. To describe what you actually feel is very, very difficult. And I, as your physician, want to know what you feel, because I've got to assess whether my treatment is working. And really, I want to know what's affecting your daily life and how you are going to live with your tumor. So it's very important that you document what your symptoms are and what you really feel. A bit of pathology. I also lecture, I'm a senior lecturer for medical students, so we always want to go to basics. And I think you, with the condition, should also know what is going on. We can, as you know, measure the markers of your tumor, the NSE or synaptophysin, and more importantly, I think you've all heard of chromogranin. And you've been hearing about Ki67. You all know your Ki67, I'm sure. And there are other ways we can look at how rapidly or not your tumor cells are dividing. Now, a lot of these cells contain granules, and they also have, they synthesize 5-HT, which actually goes on to produce serotonin, 5-HIAA, which is a metabolite that we measure in your urine to find out how your disease is progressing, or not, as the case may be. But you need to know why these metabolites are useful. It is because, I think Professor Barn hinted at it, if you look at your CT scan or your Octio scan, which is what most people have, it's difficult to tell whether you're responding to any intervention, any treatment. And we need these objective data, and measuring the metabolites is one such objective data. This is not to say that how you feel and your quality of life is actually the essential tool for determining progress. Now, you've been hearing all about somatostatin analogues, and no doubt I should be repeating. But the main somatostatin receptors are 2 and 5, which octreotide binds to. Lanreotide seems to bind more to somatostatin type 5. And that is what octreotide is. Now, both SST2 and SST5 internalize, and this occurs after the octreotide binds to them. Some of you will have had indium therapy, indium octreotide therapy with Dr. Reed, and this therapy depends on radiation that's emitted. In fact, it's a characteristic X-ray called the Auger electrons. We don't think they're very powerful, and indeed we're still not proven for sure their effects. So we do need more powerful radionuclides, and mostly now we use beta radiation, which are destructive. Some alphas are being produced, you'd be surprised to hear, and we're hoping in the future that, again, alpha radiation might be more amenable to some of the tumors that you have. Now, my brief is to talk about targeted peptide receptor therapy. And you're familiar with all of them. Let's start off, first of all, with indium octreotide. We started off in 1996, I think it was. Octreotide had just been produced, and I remember going to a conference in Australia, a very memorable conference in Australia, where I showed our first images using Octreoscan. And this was in a patient who'd had a liver transplant for a neuroendocrine tumor. When we did the scan, though, she had deposits all over her body except for the liver transplant, which is an interesting concept. But I feel sure that had we had the Octreoscan before the transplant, we would probably not have offered the transplant. And I will go into reasons why not in a moment. So in those days, all we had to target the neuroendocrine tumors was indium octreotide. And we did try and believe that the Auger electrons were going to be effective. But in our hands, we found that there was no objective data. The patients certainly felt better, some of them, without a doubt. And then we decided to abandon it because there were some problems with the bone marrow at that stage. The second is lanreotide, and indium-labeled lanreotide has been successfully used, particularly in Austrian hands. And this, again, binds to somatostatin type 5. And we can attach yttrium 90 to this and use this for therapy. There's one snag. In nearly all the patients that I did an indium lanreotide scan on, the scan was negative. So if this original scan is negative, you cannot then go on to targeted therapy. I have got 1 or 2 cases that had yttrium lanreotide, but there were very few. What about yttrium labeled onto octreotide? We were involved in a trial using yttrium octreotide. And this was actually a multinational trial. I think some American centers were involved, and Australia, etc. But in the end, we did not proceed with that because there were some problems with toxicity with the kidneys. Then we go on to the latest now, peptide radionuclide, lutetium. This seems to be really quite effective. Let's just see. Lutetium is labeled with 177, lutetium DOTA is labeled with 177 lutetium. The radioactive decay shows that it is a beta emitter, which is very important, as I've indicated, for therapy. Now, if you look at the reference given there in the Journal of Clinical Oncology, at that stage they had treated 131 patients with this peptide. And there are more up-to-date results, but I don't want to spoil the results because they're soon to be published. At that time, we got what were really promising data, which led certainly I, for one, and several others to offer this therapy. Now, with lutetium octreotide, I will give you an example of a patient in whom this treatment took place and explain how we selected the patient for therapy. There are other peptides in the making. Bombesin is one that I think may have some application to neuroendocrine tumors. NPY actually and Y1 analogs are related to, interestingly, appetite and obesity. And we may find that you don't just have surgical banding for your obesity. We might be able to attack where the problem lies with radionuclide targeted therapy. But that's very much in the future. Now, how do we assess response to treatment? And you heard from Professor Baum that imaging is obviously a good objective way of determining response. But I believe that it's you that determines response, and that you have to tell me how you're feeling and whether the treatment has made any difference. I will try and make sure we have all the objective data as well by measuring things in your blood and in your urine. And the imaging, though, at the moment, if you go on the criteria we're supposed to use, depends just on size. And I think Professor Baum has just indicated to you that we want to look at both size and metabolic activity. That's really the important way of determining objective success will be measuring the metabolic activity of the tumor. So quality of life, I feel, is really essential. And with all my patients, they do have validated quality of life questionnaires, and they also tell me and document their improvement. And you've heard about these prognostic indices, that tells us how your tumor is going to behave, whether the tumor is going to be responsive to a particular therapy or not. And we're back again to the key 67. Now, what we found in our experience was that survival, for instance, did not depend necessarily on your key 67, but on the location of your primary tumor. So if you had a foregut tumor, you had a better prognosis, or midgut, than a hindgut tumor, or tumors outside of the gastrointestinal tract. what we have found from actuarial survival rates are that if you have a neuroendocrine tumor, you're likely to be alive after 1 year. This is from diagnosis, and of course you all know that you all present at different times in your tumor history. So it's very difficult to really say what these figures really mean. But it does seem as if even at 10 years, there is a good chance that you will be living. Now, my conclusions are really to do with where we are now, that we do need more specific diagnostic radiopharmaceuticals. We need to have specific targeted therapy radiopharmaceuticals. Survival is not dependent on tumor type, but where your primary is located. Molecular imaging with PET, as we've just shown, is going to be the important thing, and I think you should combine it with your Ki-67 to give you some prognostic index. And I'm going to end with a patient, not from here, not from anywhere. The patient gave his permission. I presented him at one of our grand rounds, and he was present. 61-year-old civil servant at a local hospital. He'd just gone in to have arthroscopies done. And after the arthroscopy, he developed abdominal pain, sweating, vomiting. And it's a day procedure normally. But he stayed in bed. This is back home. He'd had no previous episodes. A week later, he had a CT, and this was followed by a laparotomy. And he had his appendix removed, but was noted to have ascites. This is fluid usually related to liver problems that accumulates in your abdomen. He also had lymph nodes on CT and at laparotomy. Biopsy of these lymph nodes, so quite out of the blue, unexpectedly, revealed carcinoid. He then said maybe he flushed. Again, he described it as feeling hot. And the most important thing was he had no diarrhea. There was no family history except that his father had always felt hot. He was taking those drugs on the left, and by March he felt a lot stronger. He had more stamina. He now admitted, I think this is him not really recognizing his symptoms, he admitted to flushing every day. But he felt 100% better. He was quite an optimistic man. I think most of you have to be optimistic, but I think it may also be part of the condition. Try and be optimistic, because things will get better. So he had what would be our baseline investigations for anyone who presents with a diagnosis already of neuroendocrine tumor. CT scan, an MIBG scan. The reason for doing these scans is to determine whether we could offer targeted radionuclide therapy. So for instance, if the MIBG scan is positive, we would offer MIBG therapy. The indium octreotide scan is also very helpful, not only for confirming the diagnosis and staging the disease, and by the way, we do suspect, Professor Barr, and CT, yes, exactly. So, I mean, you don't have to have PET, by the way, that's what I'm trying to say, but I'm not stealing his thunder. Of course, we have somebody from the funding side. I think we definitely want PET, don't we? PET-CT. We also measure in the urine the 5-HIA, and we measure crimogranins A and B. His CT scans showed progression of liver lesions, and we found a small bowel primary. So he was admitted for surgery, and he had both small bowel resection and RFA to liver lesions. I think we're getting RFA next, are we? Sorry, I don't know if we've already heard what RFA is. Radiofrequency ablation. So this was done intraoperatively. He lost a lot of weight post-op. But few months later, he was beginning to get better, but we again noted that there was further progression of the liver lesions, and there was now evidence of lymph node enlargement around the aorta. So what we do for all patients now is they go to the multidisciplinary team meeting, and we discussed the therapeutic options for this patient, and those were listed there. He really went on to admit to diarrhea 8 times a day. I have to tell you, when he was sitting in front of the audience, he told the truth and said it was actually 15 times a day. So please don't be shy about talking about your bowel actions and what they like and how many times, because this is your life. And one of my old bosses used to say, if you got amoebic dysentery, you became an appendage of your colon. And I think if you have carcinoid, you become an appendage of your bowel. You cannot move anywhere if you're going to the toilet 15, 20 times a day. Anyway, we tried him with interferon. And he thought it was okay first time around, but by the third time, although not bad, he really did not want to continue. He also developed, I think, a rash, which we thought was due to interferon. He was better. He said his diarrhea was no longer so violent, and I thought that was quite an interesting way of describing his symptoms, that the diarrhea was no longer violent. And he then started having dizzy spells, and we weren't sure whether this was secondary to interferon. So anyway, we stopped the interferon. And it was said at the MBT that we should discuss lutetium therapy with him. Now, why would I want to do lutetium? The indications were that, first of all, and we think we should change this. At the moment, we have to demonstrate that there's disease progression. And as usual, that means we're leaving things rather late. Maybe this patient should have had their lutetium on day 1, not after lots of other things have happened. So we will have to produce the evidence for that. But at the moment, we usually wait and we look and see if there's disease progression. The second thing was his only licensed therapeutic option would have been MIBG therapy, but his MIBG scan was negative. The indium octreotide scan was definitely positive to quite a degree. I can't give you the number. But I also measure the patient's renal function, the GFR, and you will see why, because a lot of the radionuclide is excreted and is within the kidneys. Not as flashy an image as Professor Barnes, but this was his negative MIBG whole body scan. We do SPECT imaging, that's the 3-dimensional imaging as well. But this was actually the octreotide scan. When he first presented, there were only a few liver lesions in 2005, but by 2007, there's several now. There's obvious disease progression, and there's paraortic lymphadenopathy, and there's lymphadenopathy also in the pelvis. Now, I get pretty pictures too, Professor Barnes. This is, we enjoy this.
You got 2 minutes.
Nearly finished. So, just to show you the images to show what we call co-registration or fusion. So even if you do your CT scan separate from your octreotide scan, Dr. Reed, you can fuse the images and get... I know.
You never get the CDs.
You're getting them now. And here you can see the lesions both on CT and on the octreotide scan. And they're very beautifully demonstrated where the paraortic lymph nodes showing very nicely co-registered. And this regime is the patient has 4 cycles of lutetium. And I hope you can see in progression that there is actually a change with the treatment, but we can measure this. And just so that we have a bit of fun, my images also rotate. This is just for demonstration purposes only. And as far as the patient was concerned, we tried to do some objective measuring, and there's the graph showing their response with the 5-HIAA and the chromogranins. So the patient, though, was the important thing. How did he feel? First of all, his weight remained stable. He felt more controlled, hardly any flushing, very slight diarrhea, and all parameters had improved. So we're back to my final conclusion, which said before that we do need to look at SPECT CT and PET CT if we want to make the diagnosis, but more importantly to stage the condition, because you get a whole body view straight away. And then thirdly, I want more work done on gathering the patients together onto a database. We're all in smallish establishments. I mean, even the whole of Europe, there will only be so many patients with neuroendocrine tumors. And we are trying to establish, certainly in Europe, European guidelines, European research, and so that we can give and share information. Because at the end of the day, we can only persuade people if we have the data to show that the intervention or the therapy actually works. Thank you very much.